Good evening.
Good evening.
So, my patient is a 58-year-old lady with bilateral knee osteoarthritis, non-diabetic, no any medical positive history except her BMI is 39.1. This was the pre-op X-rays, normal varus osteoarthritis, and this was the post-op, immediate post-op X-ray. That's the lateral X-ray. So she came to me after 4 years with complaints of pain in the right knee. There was a history of a trivial fall while getting down from the bed. There was no other complaint. And this is the X-ray.
So, are you implying that the fall caused the shift of the component?
I don't think so, because the fall was, she just had a getting down from the bed.
So this is a 4-year post-surgery?
Yes.
Do you have any X-ray at 2 or 3 years?
No, I don't. But she was pain-free. She was pain-free till that interval. And she came with this X-ray and pain and effusion in the knee.
Yes. What's your interpretation?
So I did, and this is the oblique X-rays. The hematological workup showed that the ESR was slightly raised, 40, CRPs were around 10. The knee was aspirated twice, which didn't grow anything on the culture. So I believe it was just a failure of the implant. There was a varus collapse of the tibial tray. Maybe, so I don't know the issues, whether it was with the implant. Of course, there were issues with the patient.
Okay, so to get that kind of answer, go back and see the pre-op first.
Yes, sir.
Pre-op. Okay, so the patient with varus deformity has a reasonable bone, as seen by the trabecular bone, both on medial tibial plateau and femur. Okay, post-op X-ray now. So, what do you see is the issue?
I think there is a little medial overhang of the tibial tray.
Yes, but that would not cause sinking. If you extend the tibial stem by a line, it will cut the lateral cortex.
Maybe.
Right? So the tibial cut is into varus. And if the patient is heavy, it will collapse into varus. So show the most recent X-ray.
That's the most recent.
That's what happened, right?
Yeah.
So it's loose and it is collapsed into varus. So treatment of choice now is
to do a revision.
Yeah.
With a stem.
With a stem. And what kind of device you are going to use?
I believe the ligaments may be good. I had kept a constrained implant.
Yeah, ligaments are usually good in varus collapse. Medial side ligament should be good. So any device which either you can use the same implant and a appropriate cut and a longer stem on the tibial side.
Yes.
Correct the deformity, or revise the whole thing and put a hinge. Those are your choices. Show us what you did.
So I revised it and I did a PFC with stems in both the femur as well as the tibia.
So you all can learn, in the last case, one principle, that anytime you do a revision surgery, even if you don't use stems, because a stem automatically gives you the correct alignment because of the medullary canal. And if you don't have that, I have a special tool which I have devised, a 1/4-inch rod and a 90-degree plate like that, and a handle. So after you cut, put that in, and you know immediately how the tibial cut is. Is it neutral, varus, posterior slope, anterior slope, and before you put longer stem. Now the stem automatically gives you an alignment, but does not give you bone cut. So you have to have a horizontal 90-degree bone cut, and then use the stem to align the device. So you did a good job. The only thing in such, anytime, as I said earlier, femoral stem greater than 11 centimeter from the box area, 11 centimeter. When you go and in a short person, that will be even 10. It starts hitting anterior cortex and a source of pain. All right. So if you can see in the lateral view, you are seeing it is kissing the cortex and can be a source of end-stem pain. Arun?
And therefore, I think the biomechanical studies have suggested that a short cemented stem has as much strength as a long cementless one.
Yes.
So you can avoid that problem, especially in our patients who have more anterior bowing than this particular case.
Bob Booth wrote a paper on that topic. So stem between 4 to 8 centimeter and cemented on the femur. And it gives a good fixation. As a matter of fact, both on tibia and femur, 6 centimeter on the tibia and up to 8-10 centimeter on the femur. If you get cement fixation, it's quite robust. Beyond that, cement doesn't do any additional fixation or stability. So, thank you.
Thank you.